Welcome to the Treasury Building. My name is Ben Siegel, Deputy Comptroller for Policy, Public Works, and Investment. Thank you all for coming out on a somewhat gloomy day. I promise we'll get you out before the rain hits. And we're excited to have a really interesting conversation today about our latest report. And that is why we are here today. We are here to discuss our new report released just this morning on the impacts of healthcare to Maryland's economy. This is the latest report from our team that looks at Maryland's economy and issues relating to revenues, to spending, and to the economic health and well-being of the state. As you can see on the screen here, we've put out over the past couple of years a series of reports that look at the state of our economy and key issues that look at state spending and areas of economic analysis in our state. For us, within the Office of the Comptroller, we view our duty here as bringing together data and key information that we can share with policymakers, with stakeholders, with the public, to help inform policies in the state. As you can see, our URL, marylandcomptroller.gov/research for all of our reports, and we have fact sheets out on the table if you'd like to grab one. So today, we are here to talk about the healthcare report. This is our first report where we've taken a close look at a key industry driving Maryland's economy. You've got the QR code there. You can take a photo of that and download the full report. And then we also have fact sheets circulated throughout the room. Before we jump in, I'm just going to share a brief overview of the report. What is in here? So this report analyzes the recent growth of the healthcare industry in terms of jobs and what is driving that growth. I promise this is the only chart we're going to have for right now for today, but this shows you that yellow line up at the top. That is healthcare, and what we're looking at are jobs. So it's a look at jobs by industry in Maryland, and you can kind of see two key characteristics about that yellow healthcare line. One is it's the most jobs, and two is if you look in recent years, really going back to just after the pandemic, it's the fastest growing industry. And really, in recent years, it's been kind of the only industry that is adding jobs at a significant clip here in the state. In addition, the report looks at the types of healthcare occupations in Maryland, including demographics and wages, and it compares us to the U.S. overall and to our neighboring states. We also analyze key economic activity metrics in the report, including GDP, spending, and the multiplier effects of the healthcare industry on the overall economy. The report explains how the healthcare industry is a bit different from other sectors in the economy in that it doesn't adhere to typical market forces due to things like third-party payers for services and non-discretionary demand for care. We all need health care at all times, no matter what's going on in the economy. However, that doesn't mean that the healthcare industry is not vulnerable to outside forces. Economists like to call healthcare recession-proof, but it doesn't mean that it doesn't come with its challenges. And we conclude the report by analyzing some of these key challenges facing the healthcare industry right now, from Medicaid and Medicare cuts to challenges with affordability and rising costs, to workforce shortages. We also look at some of the opportunities for healthcare so that it can remain an engine of economic growth here in Maryland. We're going to get into these topics a lot more with our fireside chat and then with a panel of experts, which I will turn over to in a minute. But first, let me just state that with our fireside chat, we'll have Comptroller Lierman and Health Secretary Seshamani, who will have a conversation about the report and what healthcare means to Maryland's economy. And we're really excited to have the Health Secretary here. She brings a unique perspective to this conversation as a healthcare practitioner, as the former Deputy Administrator of the Center for Medicare and Medicaid Services, and as an Oxford-trained health economist. I hope she gives us a good grade on our report. Following the discussion, my colleague Danny DiPietro, our policy research director, will moderate a panel of subject matter experts and practitioners who will dig a little bit deeper into these topics. So finally, in closing, I just want to thank, on behalf of our whole team, the many organizations and partners who helped us with this report by providing data, by helping us to understand the data, by reviewing report drafts, by convening and taking part in conversations with experts and stakeholders across the state. We especially want to call out and thank the Maryland Department of Health, the Maryland Insurance Administration, the Maryland Healthcare Commission, the Maryland Health Services Cost Review Commission, the Maryland Hospital Association, and the Hilltop Institute at UMBC, who were just really indispensable in helping us put this together. And then finally, in closing, I just want to acknowledge our team who put together the report and today's event. Our writers and researchers, Danny DiPietro, who I mentioned, and Annie Alexander, our data scientist, who did a fantastic job on this, and our amazing communications team who put today's event together, which takes a lot of hours, a lot of sweat, a lot of work, led by Adam Abadir and Renee Alfonso. Thank you, guys. And with that, I'm going to turn it over to the Comptroller and to the Secretary to get our fireside chat started.
Thank you so much, Ben, and good morning, everybody. Thank you so much for joining us here at the Treasury Building of Maryland. We're honored to have you, and if this is your first time, welcome to your Treasury Building. It is such a pleasure to have you all here, including our chair, Senator Pam Beidel, and our MIA commissioner, and all of the public officials, and all of the folks who helped us with the report. Thank you all so much. And thank you, Madam Secretary. Also, thanks to Team Comptroller for all of their efforts. It's a pleasure to work with all of them, and feel very, very fortunate to be here. So today we're going to talk a little bit about this report, but also about your perspective on what's happening in the healthcare field. I know we have a fire. That's why we have to have the windows open, because this heats us up. Yes. So, Madam Secretary, our research found that the healthcare industry in Maryland, as you just saw on the slide, it employs over 427,000 people. That's huge. And it represents 16% of all jobs. So we also found that the industry accounts for 8% of the state's GDP, and 13% of total wages in the state, which, as the revenue administrator for the state, something we care a lot about. So can you set the stage for the audience by describing at a high level sort of the scope and the strength of the healthcare industry in Maryland from your perspective, and what data points matter in your analysis?
Well, I will, and first, it is great to be here with you, and huge thanks for putting this together. I will say, as a health economist and as a physician, it's so important that we remember health in the context of the overall economy. And so I think that this report and the question you asked me is really relevant, in part because, as you highlight, healthcare is a major part of our economy. It is a critical part of our society when you think about employment and when you think about how central health is to people being able to literally live and figuratively live. And so as I think about health, it really is about how can health be that driver and the foundation for all the ways that we want our society to be as great as it can be for people. And I will say that in Maryland, we are definitely seen as a leader in the country in this regard. I was actually just at a conference with national health leaders where so many people say, what you have in Maryland is so special, and we're trying to figure out how to get that to other states. And what is so special about Maryland? We have a unique model in Maryland whereby the healthcare system, the hospitals, are financed not by how many heads they put in beds, by how we're keeping people healthy. So we have a global budget that we work under that enables everyone to be aligned on keeping people healthier. Because when we talk about the amount of money that's in healthcare, the amount of, workforce, et cetera, we want that to all go towards keeping people healthier. That's ultimately the goal. And so making sure that we are directing our resources in that way. And so most recently, we just launched our medically tailored meals program. That is something that is being funded through our healthcare system to provide healthy food to people with diabetes who have come to the hospital and screened positive for hunger and for food insecurity. And that's a perfect example of where we can use the incredible amount of healthcare dollars that are in our system to actually getting to the root cause of what is making people not healthy. And I think that is the lens in which we want to look at how our healthcare system works and what is good growth and good support for the overall economy.
So to dig in a little bit on the economic side of it too, is we look at the healthcare workforce in the report and we found, of course, that healthcare workers in Maryland are disproportionately women, Black residents, and immigrants. And more than half of the state's healthcare workers are Black residents, and roughly 30% are immigrants, far higher shares than in neighboring states. And nearly 80% of the state's healthcare workers are women. And this industry can create economic opportunities, right, in every part of the state, but that also notes a large dependence on our immigrant population, and we have, of course, concerns at a national level about what that means. So, in this new administration. So I'm curious if you are seeing any concerns when you are out and about the state or talking with folks about what the growth of the industry means versus sort of oppositional forces at the national level to tamp down on immigration, and how those workforce challenges may present themselves in healthcare access.
Yeah, I think that our healthcare workforce, there have been, issues with shortages in our healthcare workforce, we know, in terms of behavioral health, in terms of primary care, and particularly in underserved communities, both rural and urban. And I think that presents a huge opportunity, in part because of some of the demographics that you shared, where we have the ability to tap into those very communities that may be marginalized or may have additional stressors on them, which, by the way, we all know those stressors impact health, that we can tap into those communities to be able to get people into our workforce. And so I think that's a perfect example of how health and the broader economic outlook of a region are intricately connected. Because if we can, for example, as we are doing, invest money in people who have recovered from substance use disorder, and they can be trained to become peer recovery coaches, they are then able to do something that other people who don't have that lived experience can do. They are able to connect with others to help them improve their health. And it gives them a path for economic opportunity and stability in their own lives, which, as we know, will then further fuel the economy. It will lift those local communities. And for that individual person, it decreases the risk of relapse. So there are multiple win-wins in that way. If we tap into the healthcare workforce need in a way that does address some of the inequities that we have in our society and have that be an engine for opportunity and for growth.
Thank you. I want to dig in on one other space in the workforce shortage around our aging population. So we have, 65 plus is the fastest growing population group in Maryland. And I'm a member of the sandwich generation, right? I know I have aging parents.
As am I.
Right, that we're taking care of, and young kids. And at the same time, we see sort of 40% of nurses plan to leave the workforce or retire in the next 5 years. And the national turnover rate in the home health industry, healthcare support workers, in 2024 was 75%. And these are folks who are, they're folks who are working in the home, who are helping some of our aging, residents. So at the same time that the sort of the baby boomer population is aging, and our state population is aging so quickly, do you see, is this something that you encounter when you're working around the state, meeting with people and talking with your team about how do we address this this confluence of events of both the high turnover rates, but also, and people leaving the workforce at the same time that age population is really driving up demand?
Yeah, I think you are exactly right that we have the aging of the population that adds pressures onto the healthcare system. And I think, again, that's where crisis meets opportunity, where, having conversations with people who are in the workforce about what it is that motivates them, what it is that drives them, what it is that brings them joy, and how we can tap into that. And one avenue is through apprenticeship programs where you can bring up the next generation, and it also gives people who are currently in their jobs, okay, here is a way that I can pass this on to a future generation. And I think this also comes back to some of what we were talking about bringing healthcare back to be local. In a prior role before I ran Medicare, I led community health for a major health system, among other things. And what's the first word in community health? It's community. And I think really for all of us to be able to tap into that is so important, especially now. When there are all sorts of things that are coming at us, what is it that keeps us all grounded? I think that applies to healthcare and to the healthcare workforce, but also applies more broadly. And so I think that's just the investments we're making in apprenticeship programs is just one example of how we're trying to tap into what underlies what drives people in the healthcare workforce and how can we further nurture and support that.
That's great. Thank you. Apprenticeships are sort of it's such an important part of growing our economy and ensuring that we're upskilling our population and young people so they have opportunities. So it's exciting to hear about it in the healthcare space as well. So the topic of the day is affordability, right? Certainly it drives so much of what we focus on these days is how do we ensure that we're building a more affordable Maryland, given that we're a higher cost state overall. And so we are losing residents, right? Our last report was all about sort of the high cost of living in Maryland, and we focused on the cost of housing, but we know that residents are also feeling squeezed when it comes to groceries, energy bills, and healthcare costs. So in this report, we find that there are some unintended consequences of healthcare growth, right? Chiefly, we all pay for it. Governments, employers, patients, and over the years, we're paying more for sometimes the same services and procedures. So we worry about the sort of crowding out effect that this phenomenon creates. When individuals, businesses, and governments spend more on healthcare, they have less to spend elsewhere, perhaps on housing, on childcare, food, education, et cetera. So curious, do you have, well, I'm not even going to ask, do you have concerns about affordability in healthcare? Because yes. What are your concerns about affordability in healthcare? And can you talk about what you see as some of the cost drivers and how the state is reacting to that and what it can do to insert itself to help with curbing costs for Marylanders?
Absolutely. So yeah, you could have asked me, am I concerned about affordability? And yes, my answer would have been yes. I will say affordability is an issue in a very serious way, because if people cannot access the care that they need early on, if basic health care is not affordable, it's not like a disease process says, okay, well, you couldn't afford to go get that, cancer screening. You couldn't afford to go to your primary care doctor, so we'll just leave you alone now. Instead, what happens is people get sicker, and it becomes even more expensive to treat. And so a lot of what we are trying to do in healthcare, and this is very much in partnership with our physicians, our hospitals, our insurance companies, our businesses, and people in Maryland, because as you said, those higher costs get passed on in premiums to everyone. We are all working on how do we spend that healthcare dollar in a smarter way. And so how do we invest in primary care? And how do we have our Prescription Drug Affordability Board, which has the broadest mandate of any of the state affordability boards in the country to set upper payment limits on high-cost drugs. How do we make sure that we are enabling that affordability at that front end so that you are keeping people healthier, so then you don't need to get to that back end of the really, really, really high cost as often? I think that is the key. How do we spend money in a smarter way so that we are improving care and improving health outcomes?
Right. That's helpful. One of the other things that our report talks a little bit about is, recognizing that it can be hard for labor-intensive industries to disrupt rising costs. We talk about some of the opportunities for cost savings as well, chiefly structural shifts in healthcare financing, like directing more investment into public health, primary care, like you're talking about. We also briefly talk about the potential of AI, right, to improve productivity and what that will mean in cutting down on the things that take doctors and nurses away from their patients, but cost healthcare systems a lot of money. So that's an exciting thing too. So we know that there, unfortunately, are impending cuts, right, to Medicaid funding and eligibility, reductions in funding to hospitals in Maryland from Medicare as a result of actions taken by the Trump administration. Estimates from your office, included in our report, are that 130,000 Marylanders are likely to lose Medicaid coverage, and that the state is likely to lose about $2.7 billion annually in Medicaid funding. That is a pretty staggering thing, and I think it's worth just putting an underline on that and noting that we are not alone in Maryland. It doesn't matter if your governor is a Democrat or a Republican. Every state in this country is going to lose funding, and its residents are going to lose access to Medicaid as a result of H.R. 1 passed last year. And hospitals are also likely to see an $870 million reduction in federal funding. I think the MDH estimated by 2032. So can you talk a little bit about these cuts to funding and coverage and how, as a state, we are starting to think about moving forward?
Absolutely. So I will start with those estimates are based on what, the law passed in our current state here. And we are working hard for that not to be the case. And I will actually pick up on where you left off with our prior conversation on technology. Maryland is a leader in the country in terms of having a unified application screener, Maryland Benefits. So for SNAP, for certain types of Medicaid, for LIHEAP, TANF, that there is one place people can go on their mobile phone, determine eligibility, get screened, get their application going. We are leveraging that platform to really automate as much as we can of the additional requirements that are now being imposed by the new federal law. And I cannot overemphasize how important that is, because when you look at other states that have implemented similar provisions in the past, like Georgia, for example, implementing work requirements, the main reason that people fell off of the Medicaid rolls was bureaucratic red tape. So we are working to bring in data sources so that as much as possible, we can automatically determine eligibility for Medicaid. And we also have the benefit in Maryland of having CRISP, which is a national leader in the Health Information Exchange. So, for example, there is an exemption from the work requirements for medical frailty, which we're waiting for guidance from CMS. We have CRISP that can very easily bring together all of the diagnoses that somebody has to in a more automated way determine if they are exempt from those work requirements. So really trying to leverage technology and also leveraging our community. It comes back to what I was saying before about how unique Maryland is, that we are all very much in this together.
Right.
It is in everybody's interest to keep everybody enrolled who is eligible. Yep. And so we we have been having roundtables with people from across sectors, not just health, also thinking about philanthropy and business, community organizations. How do we get everybody out with us, pounding the pavement and doing outreach so that when the time comes for people who are on Medicaid to have to take action, they know what to do, they have people helping them. And I'll come back to, it's all about the community. That people feel when, again, there's a lot happening, how do I navigate this? I'm busy just trying to put food on my table, which with SNAP, changes also becomes more difficult. How do they feel that the state of Maryland has their back?
Yep.
How do they feel that their community has their back? And that's where we are working very closely with many of you in terms of getting the word out, enabling people to understand what's coming, and really for them to feel like they have support in navigating these changes to their health care.
That's great. Thank you. And you're so right. There are these benefits like Medicaid, and in our world, it's like the earned income tax credit, right, that exist, and they become an unfulfilled promise when government gets in the way rather than helping to empower people to have access to them. And so I think it's why I love Maryland Benefits, and it's why we feel so strongly about doing our All of Government Earned It campaign to ensure people have access to the earned income tax credit. Because, passing the legislation is the first step, and actually making sure that people can benefit from these programs is the second. And it's in our interest as a state government and as an entire state, our entire population, to make sure that people who are eligible for these benefits and these tax credits access them, because then those families can do better, right? They can move into the middle class. They can get the healthcare access they need. The kids are getting their asthma treated so they can show up at school every day, right? So it is really important for government to have these tools to ensure that people can access the services that they need and that they're owed by law, right? So thank you for that, and thanks for all your work on it. So looking into your crystal ball, there's a lot of changes coming to the healthcare ecosystem, but also to the industry, right? To the healthcare industry, whether that is home healthcare, whether that is doctors' offices, whether that is hospital settings. So talk us through a little bit what you see coming, whether it's because of AI, whether it's because of HR1 or a confluence of all of this, what you see coming in the next few years.
Well, I will say, if there are three things that I wish I had, it's a crystal ball, a magic wand, and a superhero cape. That being said, I think that we are definitely at a critical moment for healthcare, for many of the things that we talked about here. And we have to meet that moment. And I think the way we meet that moment is, again, a lot of what we talked about here. How are we coming together to think about healthcare and health in a smarter way? That we are really addressing the root causes of what leads people to not be healthy, and addressing that to prevent issues down the road, which end up being more expensive and then don't enable people to live their fullest lives. How are we better connecting traditional healthcare, not only with public health, but also with the broader economy and the strength of our communities? And again, I've given some examples here with what we're doing through our AHEAD model investments, tied with our rural health transformation model investments, where investing in our local farms through rural health transformation dollars from the federal government supplies the food for the medically tailored meals and produce prescriptions and healthy eating that we want Marylanders to do. So you're keeping Marylanders healthy in a way that actually boosts the local economy, both in and out of healthcare. And I think that is the direction that we have to move in to really meet this moment, to be able to enable people to continue to live healthy lives in this time of change.
That's great. Thank you. Thanks so much for being here. Thanks for your leadership of such an essential and important agency in our state through a time of true tumult. It is a really challenging time, but this work is so important. And we produce reports like this because we hope that they're helpful to our agencies, to our policymakers, and to all of you and our public to understand the challenges, but also the opportunities that are presented to us. So thanks for your partnership, and I look forward to next up. We have a wonderful panel of some of the leaders in this industry who are really making sure that we're moving forward as a healthier and more affordable state. Thanks, everybody.
Thank you.
Great. I'm not usually behind the mic. Good morning, everyone. Thanks so much for joining. So I'm going to move us to the panel portion of the discussion here. Sorry, I just took the stairs. First, I'm just going to introduce our panelists for everyone's benefit. We have multiple types of doctors here, so I will specify. So first is Dr. Douglas Jacobs, primary care physician. He's the executive director of the Maryland Healthcare Commission. I'll give you like 2 sentences on everybody's organization. The Healthcare Commission is an independent regulatory agency whose mission is to plan for health system needs, promote informed decision-making, increase accountability, and improve access in a rapidly changing healthcare environment by providing timely and accurate information on availability, cost, and quality of services for policymakers, providers, purchasers, and the public. Thanks for being here. Next, Dr. Morgan Henderson, economist. He's the director of analytics and research and the principal data scientist at the Hilltop Institute. The Hilltop Institute is a nonpartisan research organization at the University of Maryland, Baltimore County, UMBC, dedicated to improving the health and well-being of people and communities. They conduct cutting-edge research on data analytics and translational research about the health and well-being of people and communities. They provide this to government agencies, foundations, nonprofit organizations at the national, state, and local level. You've probably seen their reports used by the legislature and others in Maryland. Next, we have Melony Griffith, who's the president and CEO of the Maryland Hospital Association. The Hospital Association is a membership organization that serves Maryland's hospitals and health systems through collective action and shapes policies, practices, financing, and performance to advance healthcare and the health of all Marylanders. And finally, Claudia Balog, the Assistant Director of Research at 1199 SEIU, United Healthcare Workers East. They are the largest healthcare union in the nation, and Claudia and SEIU cover Massachusetts, New York, New Jersey, Maryland, Florida, and DC. Their mission is to advocate for quality care and good jobs for all of their members, ranging from frontline caregivers in hospitals, nursing homes, home health care, pharmacies, et cetera. So thank you all very much for being here. So that's a perfect place to start. I think just a little bit of a preview of the types of roles that the healthcare industry supports. My first question is going to be about sort of the size and scope of the healthcare industry. I think as the comptroller and secretary referenced, it is the state's largest industry, employing over 427,000 residents. That's 16% of all jobs in the state. The next largest industry, education, is 281,000 jobs. So really, really sizable. I think people might have in their mind sort of one image when they think of a healthcare worker, but this report dives into the industry data, which means anyone employed by a healthcare organization or entity. Could you all talk a little bit about the scope of the healthcare workforce, like the different subsectors that a worker could be employed in, and the different wide range of roles that the industry supports? You could touch on demographics, geographic reach, the different care settings, whatever most resonates with you. So I will start with Dr. Jacobs, and we'll just go down the line. Thank you.
Sure. Thanks for the question, and thanks for having me. And also congratulations on the report. The size of the healthcare industry in Maryland, as was described, is huge. It's such an important piece of the state. And there's so many different aspects that we could go into here. I'll maybe touch on a few that resonate. The Maryland Healthcare Commission is focused on access and the type of workers that we have in the state. One of the areas that we know is just so important is access to primary care in particular. It's the one type of provider where the more the supply that we have, the greater the health outcomes in terms of life expectancy. And we actually see a reduction in disparities, and it can lead to reduction in emergency department visits and inpatient admissions, which is especially important in this state in particular because we have the global budgets model. And so some of the salient aspects of the report that I'll touch on, ambulatory in particular is growing as part of the healthcare workforce. And I think that that's really important. And it's also based on some of the models that we've had historically in this state. The MD PCP program, and now the PC Ahead program, there's been a real commitment to primary care as a result of the model, which has been, I think, reflected in some of the data. And I think that the other piece that maybe I'll just touch on is, as a result of the model, we're also thinking about where's the most appropriate site for some of this care. And so in some instances, that might not be a skilled nursing facility for post-acute care. It might be a home health agency. And we see a lot of the growth in, for example, home health aides that can provide some of that work as well. And also, there's areas that we should monitor, and so we can get more to that in subsequent questions. But thanks.
Thank you.
Yeah.
Thanks, Danny. Just to add to Dr. Jacobs' answer, it's a big umbrella, the healthcare workforce in Maryland. People probably think physicians, they probably think nurses, and it's a lot, 20,000 physicians-ish, 50,000 nurses, but there's 427,000 people total. So there's a lot of different people working in this, a lot of different jobs. It's difficult to keep track of all the different kind of specialties and roles. I think the report does a really nice job of tracing these trends out using a lot of nice data. It's a jobs engine. I mean, clearly, it's some of these jobs are not terribly well paid. So that is just a kind of an aspect of the health landscape, but it's certainly a jobs engine.
Well, thank you, and thank you for this report. It's so impressive that you all were able to talk to so many aspects of the healthcare ecosystem to put this together. When you talk about the 427,000 jobs, you know, as we look at the whole healthcare ecosystem, I thought about the number that the report also talked, your previous report on education, because the jobs that it takes to populate the healthcare ecosystem requires so much activity at all levels of the education ecosystem as well. And so I wanted to just point out that healthcare jobs, the healthcare sector feeds other sectors as well. You know, I'm a social worker by training. So when you think about hospital jobs, my first job was at a hospital. So behavioral health workers, IT workers, nutritionists, hospitals alone operate 24/7, 365, taking care of communities. And I often say, and some of our members are here and some of my team, they often hear me say that these employees boot up, suit up, and show up every day to take care of communities when sometimes people present at their worst. They're angry, they're frustrated, they're scared. Some are hungry, as was stated by the secretary. Some are tired. Some are on substances. And so they show up every day to take care of communities, and it takes all of that system working together to take care of those patients. You've got to have your IT departments working, your finance teams. We've been talking a lot this morning about Medicaid. You're just going to take so many different people and so many different employees to make the system work effectively, and feeding that system is going to take all of us.
Punctuation on everything that's been said. At 1199, we represent healthcare workers, not just across the continuum of healthcare providers, but at every level of the provider. So we represent folks who are engaged in environmental services and infection control in hospitals, and the CNA, GNAs in nursing homes, and the dietary techs who are ensuring that people get their meals. And across the union, we represent the fastest growing segment of this workforce, which is home care workers, right? And one note I do want to say is sometimes I think it's helpful to look not just at the demographics, which I think this report did an incredible job on, but how we got there. And I would note that for decades, a lot of those caregiver positions were really devalued. And that was a structural issue because, for example, home care jobs stemmed from the title of domestic workers, right? And domestic workers were traditionally in the Jim Crow era exempted from wage and hour protections. And we're right-sizing that. So I think when we think about workforce, it's important to think about equity and how do we improve access for care and how do we ensure a healthy, sustainable economy. Part of that is being very intentional in looking at demographics and how we really create a robust, healthy system.
Thank you. And yes, just a note, as the report states, the home health and personal care aide occupation is the fastest growing. So it's notable that is, among the lowest paying and potentially one of the more devalued, roles, but also in the greatest demand. So thank you all. That was great. So now that folks might have a better understanding of the various components of the healthcare industry, I wanted to talk a little bit about the growth we're seeing. I believe the comptroller stated that since 2022, healthcare has added 51,000 jobs, which is nearly as many as all other industries in Maryland combined. That's just a fascinating statistic to me. Can the panel, I'm going to ask you guys to talk a little bit about where the growth is happening within the healthcare industry, like specifically which subsectors, and where as a state we want growth to happen. In a conversation with Marie at the Health Administration the Maryland Insurance Administration, she said to me not all growth is good. We want it to happen sort of intentionally in specific areas, especially as we think about controlling costs. So if you could talk a little bit about why does it matter where growth is happening and what does it mean for controlling costs and for improving access to care. And you started to touch on this a little bit in your answer, so if you want to go first, that's great.
Sure. So thanks for the question. And part of what the Maryland Healthcare Commission does is evaluate where is there need across the state for various services. And so I think that we're faced with this question a lot. And oftentimes what we can see is that if left to their own devices, there's certain motivations for building a new facility or a new practice, specifically in areas where there are not poor people, where there's people that have private insurance, where people have Medicare more, and even Medicare pays somewhat less. And so I think that matching where the growth is happening to where people actually need the services is quite challenging, but definitely something that needs to be done. And something that we're faced with pretty much every year. So it's just underlying the point, basically.
I think the report really nails it when you say not all growth is good growth. Healthcare is a weird market. It's not like the market for bananas we learn about in Econ 101. It's characterized by tremendous uncertainty. People actually don't really want to buy blood tests, they want to buy health. And so what is that? What does that even mean? It is characterized by intermediation. We have health insurance, and that smooths consumption. And it's characterized by tremendous information asymmetry. This is nothing new. This has been known for decades. Additionally, we live amidst historical circumstance. The system is the way it is because certain decisions were made decades and decades ago. And so it's very, very complex. I think what we can say for sure is Maryland is very unique. Very unique. I remember speaking to Danny a couple months ago in this report and just trying to emphasize, we are such a unique state relative to all other states plus DC. The Maryland model, it's done, I think, a wonderful job. The numbers prove that out. It has its thumbprint on our state's economy, the health economy anyway, in terms of how things are shaped. And the Maryland model, at least parts of it, they're going national through the AHEAD model. Other states are going to be doing the hospital global budgets. And so all growth is not good growth. Things are growing in Maryland. I mean, I was really surprised by the stats on the home health care workforce. I guess it's not terribly surprising. We live amidst the baby boom still. People have been saying it for 20 years. We're still saying it. We'll still be saying it for 20 more years. And so it's not really surprising, I guess, the demographic impact of this. But it's, we're in it. And so, I think the relatively low hospital employment growth, I think the report does a nice job of attributing that to the Maryland model, which again, very unique. I think that's right. And so, where is good growth? I'm an economist. I wouldn't call myself a good economist. An economist would say growth should happen where the bang for the buck is highest, in those sectors where that marginal dollar, you get the most out of it. And so this means maybe more preventative care. This means potentially lower cost sites of care, prevent people from going to the ER if possible, when they can be treated in alternative lower cost settings. It's very difficult to do that, but I think there's a lot of will in the state to try to get that done.
Thanks. Just piggybacking on that, and a comment the comptroller made in her remarks earlier, she disclosed that she's a part of the sandwich generation. I'm a proud member of the boomer group, and so I'm a young boomer. But one of the things that I think we have to think about as we think about the needs moving forward and where healthcare is trending is the fact that I and my colleagues in the boomer generation are getting older and likely presenting with higher acuity. We're sicker. We have more complex needs. And so having the team in place that can provide that hands-on care that's going to be needed is one of the areas that we need to focus. Dr. Jacobs mentioned it earlier, post-acute care is going to be a critical area. And as both of the previous speakers said, making sure that care is available in the settings where people need to be seen and that they're not being seen in the most expensive environments necessarily, but getting the kind of care that they need. So investment in the workforce is going to need to follow those same trends. The challenging part is that while the boomer generation is the largest generation that we have right now, the workforce is not. And so those young people that are choosing their careers and identifying where they're going to spend now we're talking about the fact that young people aren't spending as long in one job as we did when we were coming along and our predecessors. So attracting young people to the workforce to do the kinds of care that cannot be replaced by technology, right? That hands-on care that people are going to be depending on is going to be a critical part of our work moving forward.
Yeah, I'm a member of that sandwich generation as well. And I think a lot about the aging demographics in our state and the graying of our state. I think about it on a daily basis. I think that there's a couple of things I do want to highlight. I work in lots of states along the eastern seaboard, and Maryland is so lucky to have the model that we have. To amplify the points that were made, there are conversations right now happening in other states in our geographic footprint at 1199 where rural hospitals really are in danger of shutting down. And they don't have a health services cost review commission. They don't have global budgets. And so the importance of this model to ensuring that there is access to care, that we don't just churn people through hospital doors unnecessarily, right? So it makes total sense that you're seeing this growth in post-acute sectors. One thing, I would also like to amplify, this is national, right? So in 2024, CMS released a Medicaid access rule talking about access to home and community-based services, and really understanding that we have a workforce shortage. We're not, we have two problems. We can't attract workers into the home care workforce, but I would say even more importantly, we can't retain them. And the CMS access rule was really intentional in saying, this is a wage problem. This is a shortage problem. We have a graying population. We need caregivers. We need to keep people out of those EDs. But we also need to ensure that this workforce is stable. And I think that that's something that Maryland is, that's our next trajectory, is like figuring out how do we stabilize this workforce. COVID didn't create shortages. COVID magnified existing weaknesses in our labor supply.
Thank you. Great. I'll try to tie a few of those threads together with the next question. A lot of good comments there. So, Morgan, yeah, you talked about sort of the most cost-efficient place to get care is probably the place we should focus on growth. I think, as many of you touched on, the state is really trying to do that through a real commitment to value-based care, and we've been a real leader there. We talk in the report about sort of the opposite of that is as Secretary Seshamani said, fee-for-service care, where it is just head count, volume drives revenue. We do things differently. Secretary also mentioned, primary care has sort of the most bang for our buck. And so we're seeing more investments in those areas, and the report does sort of demonstrate that that's working to a large effect in that these outpatient care settings are growing much faster than like emergency room sort of volume, and that's a good thing. One thing I think to flag as we think about challenges, and we can pick back up on this later, is if there are big coverage losses, usually that translates to more emergency room utilization. So that will obviously be a factor working against all the sort of efforts in Maryland. So I wanted to talk a little bit more about cost and this cost efficiency. One thing that's interesting in the report is we mentioned that the industry is not particularly productive, and we mean that in the most sort of technical sense. It's very labor intensive and very hands-on and cannot be replaced with anyone but humans for the most part. But because wages have been rising, costs are of course going up, and there's not a lot of levers to pull in terms of keeping costs down unless we make these big structural shifts, which I think the state is really trying to do. So we see that costs are growing as evidenced by year over year per enrollee spending increasing for everyone, privately insured, Medicare, Medicaid. The hospital services as sort of like a consumer goods and services item is grown far faster than all other consumer goods and services since 2000. So I want to talk a little bit like, are we overpaying? What is a more efficient way to spend and invest? Does healthcare growth worsen affordability? Or sort of when does that happen, and how we will manage federal funding cuts, we being businesses in the state, individuals who are paying for their own insurance through the marketplace or elsewhere, and state governments for whom this is such a huge budget item. So sort of any comment you want to make about costs and how we manage costs, what is driving up costs would be great. I think this order is working well. We'll just keep it going. Thank you.
So what you're speaking to is the tension of affordability here. On the one hand, we might want payers to pay for all sorts of different things that could be of benefit to patients. And on the other hand, we know that if a payer is paying for something new, that can lead to potentially increase in premiums for everybody else that needs that health insurance. And so that tension has played out. It oftentimes plays out in the legislature when bills are being discussed. It plays out. We as a commission do analyses on the trade-offs, the relative benefits of covering for something new and not, and what the impact would be on premiums. And so when we think about affordability in healthcare, there really is that tension. And so we want to make sure that we as a state are paying for those things that have those positive externalities down the road. I'm using the fact this is an economy panel to insert the word externality. And so just trying to focus on that care is something that I think we're all talking about the virtues of the model. Like that is something that the model also incentivizes, is ensuring that that the right kind of care is being delivered. Because when there's less potentially preventable admissions, everybody wins. And so it allows for important discussions to happen in this state that don't necessarily happen in other states too.
Very difficult question about if we're overpaying for care. Very important question. I have a 3-year-old. I worry about her college tuition, but I also worry about that graph, the hospital prices, and I forget which graph it is. Figure 22, yes. That's worrying. That is a worrying graph. And again, it's nothing new. This has been this way for 20 years probably. And so I feel lucky to live in Maryland, though, because we really are quite different in Maryland. That graph doesn't really apply to Maryland in terms of those hospital costs going up and up and up, because of the all-payer, the rate-setting system. All the payers pay basically the same amount to hospitals, and the global budgets really incentivize hospitals to try to keep people out of the hospital rather than try to churn patients through. So overpaying is difficult. Healthcare is sometimes extremely price inelastic. If you break your leg, you go to the ER, and you'll pay whatever they want you to pay. And so this is typically smoothed through insurance. Again, like I said, the insurance landscape also complicated. I like that. I forget which table it was. Daniel, was the breakdown of who pays. We have the commercial market really is probably what we're focusing on here today. But within there, that's fully insured and that's self-funded. So this is a whole separate discussion. But it's complicated. It's fragmented. But so I would say Are we overpaying? I can't come to a simple yes or no, but I think in Maryland, we can all pretty safely say we're not overpaying, or if we are, we're overpaying way less than in other states.
Thank you. I want to acknowledge, and it's been said by others, how fortunate we are to be in this state. And the reason that I say that is because we understand that care takes all of us, providing care and managing costs takes all of us. We have an administration and a General Assembly that really is keenly focused on handling and managing some of the biggest cost drivers. We know that the workforce, and you can look at the numbers in the report, the workforce is a large percentage of the healthcare dollars that are expended. But, and I see Vinnie DeMarco in the room, we know that prescription drug costs are a huge cost driver, not just in Maryland, but across the country. We just addressed an issue, Madam Chair, in this session on overstays, patients that don't need to be in hospitals but are receiving care in hospitals, and that is a cost driver. It's an opportunity cost because while patients are in those beds that could be receiving care elsewhere, the people who need to be in those beds don't have a bed to be seen in and are probably still in the ED, which drives up the emergency department length of stay and all of that. I think that as a state, we've been keenly focused in addressing the cost drivers and managing them somewhat through the model, and where legislative remedy is required, we've been working with our legislators. There's also a lot of time spent on administrative work in healthcare that does, again, it's another opportunity cost, time that's spent resubmitting claims or, challenging a prior auth decision. Those are dollars and time spent on administrative services that could be redirected to patient care. And so those are the things that we're working with our partners on and finding. We're, again, fortunate in Maryland to have willing partners because we all understand that working together, we can address and manage some of those costs.
Yeah, totally. I think that so many hospitals are achieving the levels that we want to see in the total cost of care model. We are reducing hospital readmissions. Like, we're doing a very good job. And I think what is now setting us apart is the state is taking a really holistic look at the healthcare system as a system. And so much of this, I think the question is less, are we paying too much, but are we steering the dollars that are already in other segments of the system, driving them towards the best quality of care we can, right? So obviously from the labor union's perspective, are we ensuring that we have the workforce infrastructure as healthy as it can be to ensure that there's quality in all of those post-acute settings, whether it's skilled nursing facilities or assisted living facilities or home-based or clinics? Our federally qualified health centers are part of this mix as well. So I think that I'm really optimistic actually about Maryland, more so than some other states that I'm involved in, because we are really looking at this as a system with various pieces of the puzzle that fit together. When we improve the quality in those other spaces, when we make value-based payments in those other spaces, our costs for consumers will be considerably less.
Thank you. Yeah, I think it's interesting right now nationally. I was just at a conference this weekend, heard this shocking statistic: only 5% of healthcare dollars nationally go to primary care. I've got to believe Maryland's doing a better job because we are a leader in so many ways in this space. But as you say, sort of, it does feel like there's a very holistic look at the system, and we're driving investments to the most cost-efficient settings that will render people actually more healthy to prevent the most expensive sort of types of care utilization. So as we look ahead, we do outline several challenges in the report. Some of them the Comptroller and Secretary touched on. I'll just repeat a few. The federal funding and coverage cuts, obviously a concern. I think the workforce shortages as a challenge is really multifaceted and interesting. Combination of outmigration, and which we've talked a lot about in our other reports, and just Maryland's generally slow labor force recovery since the pandemic compared to the nation and other states. The aging workforce, we didn't talk about a ton today, but we have about 11% of healthcare practitioners and technical occupation Maryland are over 65, and nationally that number is 6%. So we have the second oldest median age of nurses in the country and fourth oldest median age of physicians in the country. So again, this confluence that they discussed during the fireside chat of aging workforce and aging population is really going to be a challenge. And then immigration policy, as the comptroller mentioned, we have almost double the amount of foreign-born residents in our healthcare workforce than the national average. So the sort of cuts to temporary protected status and parole and probation programs, also very concerning, given how many of those individuals currently work in the healthcare system, especially in areas like home healthcare. So thinking of all of that, and of course the opportunities, which we also cover, the Maryland Primary Care Program, the expansion of value-based care to other settings, the AHEAD model, potentially AI, big question mark. We don't do policy recommendations in our reports on purpose. We focus on laying out the facts and findings and then sort of deliver those to advocates and policymakers and folks that are more expert in these subject matter areas. But I'm curious, since we have you four, if you have some ideas, policy ideas about what we can do as a state to outline some of those challenges that I outlined and any others that are on your mind, and policy ideas that could help us really take advantage of some of the opportunities that we also discuss in the report or that you think about separately. Thank you.
Thank you. So I think that there are tremendous opportunities amidst the challenges. And Secretary Seshamani touched on one that I'm going to underscore with some of the HR 1 implementation and the challenges with the community engagement provisions therein. We've been really working across state agencies to make sure that individuals who should qualify for an exemption for these do get that exemption. And that's just so important because it means that those individuals won't be facing red tape and they won't lose their care as a result of missing some sort of deadline in the legislation, but that they actually they are medically frail and that they deserve to have access to Medicaid as a result. And so because we, as a state, CRISP, even though it operates in many states across the country, it started in Maryland, and we designate them as the state designated healthcare information exchange, and they've been playing a key role. Hilltop's been playing a key role. We've the Maryland Department of Health, and so many others, and so that's really been an important work that hopefully will end up having more people covered. And we know that Medicaid coverage actually just ends up saving lives too, in addition to all those workforce improvements. There's also, I talked a little bit about primary care investment. We've been touching on it. This is another opportunity with the AHEAD model. There's a requirement to have primary care investment targets. And so that is something that the Maryland Healthcare Commission is working with as part of this regulatory working group with the Health Services Cost Review Commission, Maryland Department of Health, MIA, and it's been really, and the Maryland Health Benefit Exchange, MHBE. And that process is important because we're setting these targets about what should primary care investment look like? What do we actually need primary care investment to be to fund those primary care teams of people, not just physicians, but MAs, RNs, community health workers, behavioral health workers, to really provide the care that Marylanders need. And so we're looking at developing those targets and are making good progress in consultation with stakeholders there too. And then also the rural health transformation dollars that are coming into the state are a tremendous opportunity. And I think that, so there's we talked about food as medicine, thinking more broadly about healthcare. I know that this report is healthcare focused, but increasingly we're realizing that it's they don't have access to stable food. They don't have access to stable housing. They don't have access to transportation. That all has downstream implications that I see in the primary care office, that others see when folks get admitted into the hospital. So I think amidst all the, I think tumult was the word used. There are some opportunities that I think that we as a state are uniquely positioned going forward.
Thank you. And I'm glad you mentioned the Rural Health Transformation Program. I should have mentioned in the workforce challenges sort of overview I just gave that, our rural counties have an even greater share of older residents than the state average and already have the worst healthcare shortages. So really eager to see what that program can do. Thank you. Morgan?
The challenges are many, but the opportunities are also many. HR 1, that's a biggie. In particular, the impending Medicaid enrollment losses, 130,000-ish. Yeah, and that's going to be very challenging because I think the best cost containment strategy, the best thing that makes the most economic sense is to try to keep people healthy. Healthy people, they are productive people. There's questions of moral right as well. And Medicaid keeps people healthy. The research shows Medicaid expansions that led to reductions in mortality. So Medicaid, it does a good job keeping people healthy, and it's cost effective. It's basically the best bang for your buck that the state can get in terms of trying to keep people healthy, but also the state balances that tension of having to set fair reimbursement rates for providers. Maryland does a very good job of that, Maryland Medicaid. And so trying to minimize enrollment losses as a result of HR 1 for Medicaid, that's going to be very important. The expiration of the advanced premium tax credits that just expired in January 1, 2026, that's a big deal. Maryland, of course, we have our state subsidy program. The early data is coming in, and I think that will be of paramount importance to stay on top of, because what we really don't want to see is we don't want to see a bunch of uncompensated care at hospitals. We don't want to see people deferring important care, ending up at the ED. They have to be treated, thanks to federal law, but they don't have the resources to pay the bills. This is bad for the hospitals, this is bad for the people, and so I think Maryland is well poised to try to avoid these challenges.
I'd agree. Going third is hard because these two guys give all the answers, and then she and I have to try to find something they didn't say or to say it differently so that you all think we're contributing. So, but you're doing a great job.
So are you.
I will say in this moment, I think that I agree. Maryland recognizes this moment that we're in. We're in a very complex moment, right? And I know that we recognize it because we're communicating at the federal, state, and local levels about these issues. We're recognizing that there are so many moving parts, and I haven't heard it mentioned a lot today, but the healthcare ecosystem really starts long before people end up in one of Maryland's hospitals. We haven't talked about public health and, that primary and preventive care. I saw Gene Ransom here, where providers fit into that equation, our primary care providers, and the fact that in many communities in the state, people don't have access to primary and preventive care, and therefore they come to the hospitals for their primary care. And so we are having these difficult conversations about this moment that we find ourselves in, where we are not able to define how people consume care, because we just started a few decades ago talking about health literacy and getting people to seek care and take responsibility for their own health and well-being and finding out their health status. And as we started having those conversations, many of the people who needed that care, I look at Prince George's and Montgomery County alone, there's over about 500,000 people in just those two jurisdictions on Medicaid that we're teaching, go to your federally qualified health centers, talk to your provider about, prescription drug opportunities if you're on drugs, where you can get reduced cost and things like that. And as we start those conversations, the changes at the federal level change the resources that they have available and the services that may be available in different communities. So access isn't just about having a building or a hospital, it's the services that are available in those settings and making sure that we don't allow changes to policy to cripple people's access to care because of the changing availability of programs and services. That's the moment that we're in, and it's going to require continued conversation as we try to mitigate the impacts of things that are being done to us and our communities.
Right. Well said. And I'll just point out one other stat from the report because you touched on it. Every dollar invested in public health typically yields $7 in savings across the system. And my degree in undergrad was public health, so I love talking about this again, but all these social determinants of health and how these investments can really save dollars down the road is so important. I think it's harder to prove that it's less tangible, harder to prove that these dollars are working because we are preventing the person from getting sick in the first place. Right. So I feel those are always underfunded but so critically important as we think about the whole system. So I'm really glad you pointed that out.
You gave me a great segue as well, so thank you. I mean, I think that, I referenced it earlier, but, in 2024, under the Biden administration, CMS released its access rule. And it was, in a nutshell, Americans need better access to care before they land in a hospital so that we don't actually put them onto the roles of consumers. And how do we improve that access? Well, we take those Medicaid dollars and we ensure that they're being steered appropriately to providers in a way that improves the quality of care, improves the quality of life for people so they don't land in an ED, which creates this spiraling out of control costs that lots of states are talking about. I think now that we're in the universe that we're in with HR 1, I think more than ever, our job as a state is to ensure that we optimize the Medicaid dollars we are spending. So what does that look like? We have lots of for-profit, out-of-state, private equity investors coming into the state. And I think that we have an opportunity to ensure are folks in the state stewarding Medicaid dollars in a way that really moves the needle on the quality of care? Are they using those dollars to invest in workforce? The complaints about our reimbursement rates, again, I'm coming from the workforce advocacy union perspective. There's always going to be folks saying the reimbursement rate's too low. And that could well be that the reimbursement rate is too low for all of the things we want it to do. We want to invest in workforce and higher wages. We want to invest in apprenticeships and career ladders and career lattices. We want to make sure that we have this healthy workforce to care for us as we need care. How do we do that? Well, one of the ways I think we need to start thinking, which we are, it's fantastic, is we're looking at these post-acute settings and we're saying, how can we ensure that every dollar that's spent in a post-acute setting, and that list is long, is spent in a way that really supports the healthcare system and really supports public health and the quality of care that we're receiving. So it's an opportunity for us. We're under the gun right now on cuts, but I think even if we were flush with Medicaid dollars, it would benefit us to ensure that those dollars are being stewarded appropriately.
Absolutely. Thank you. Well, that's 10:50 on the dot, so I really appreciate all of you. We're going to open it up to a few questions and conclude by 11. Ben will come around with the mic.
Just
Thanks.
state your name. We'll go here.
The question is, I think there is a realization amongst everybody here that costs are going up, the demand will raise because of aging population. The question I have for this panel is, what is being done on the regulation side? For example, a lot of the costs are being driven by state and federal regulation, and I can quote a few, that are probably not necessary. And is there any movement towards looking at all the regulations and rationalizing them to see which ones of them make sense and where we can cut costs?
Sure. Yeah. No, thank you for the question. It's complex. There's, as I'm learning, I'm 8 months into the position, and so I'm every week I learn. We have a law about that. No, I need to pay attention to the regulation there. Okay, I need to read a new regulation today. So I think we're going through and thinking. We oversee certificate of need, and so this is one area where, in some instances, there could. Our regulations might be too onerous, and in other situations, we might not have enough oversight. and so, I think that we're currently doing a review, and as I'm talking to stakeholders, learning more, that's definitely something, because we also want to. Part of when we talk about affordability, part of it is the amount of competition that's in an area, and if there are regulations that are preventing competition from happening, then that can be a problem, and we need to take a look at that. And so that's something at least that we're doing on our side more specifically, but I'm sure there's other work being done too.
Great question. When we think about costs, I think we need to think about the landscape of the Maryland population. We got Medicare, about 1 million people. Medicaid, about 1.5 million people. So that leaves about 3.5 million else. And so these are the commercially covered folks. You get insurance through your job, or your dad gets your insurance through his job, or you purchase your own coverage through the ACA marketplace. And like I mentioned, this population splits into quote unquote fully insured and then self-funded. Self-funded, the employer acts like a tiny little insurance company. That's federal law governs that. Old stuff from the 70s, can't really touch it. And so, I think in terms of regulation, I think important to consider, one of the panelists mentioned the increasing role of private equity ownership. So changes in ownership, that's a big deal because acquisitions or consolidation, that increases providers' market power, which can influence their negotiating power when renegotiating contracts with insurers. And this is the fully insured companies and the self-funded. So market power is a very big deal. There's always a balancing game. There's two sides of the negotiating table. There's providers and there's payers. And so when things happen to increase certain providers' market power, whether it's acquisitions, whether it's some sort of horizontal or vertical integration, that can really tip the scales. And so I think keeping a closer eye on that while at the same time not stifling innovation and competition, very difficult balance to strike. That would be, I think, my policy recommendation on this. Focus on market power and the role of consolidation.
Thank you. Do you want to respond?
I mean, the only thing that I would add is, and not being sure what specifically, regulations you're referring to, I would say in Maryland, we have this environment, the legislative environment and the regulatory environment, and both provide opportunities for people to respond to something that they see as a problem by passing a law or asking for a regulation to be adopted. So most of the regulations that we have in place and the policies that we have in place came from something. So it's figuring out where it came from and whether or not that need has now been addressed and that policy or regulatory decision is no longer needed, and communicating with the policymakers and the regulators. Every year, Chair Bidel and her colleagues show up in Annapolis and change rules that somebody made in a previous year.
Yeah.
Right? John Crum and the HSERC, they meet every month and make modifications to regulations that have already been adopted. The MIA, the same thing. So it's basically identifying the regulation that you believe needs to be changed and making the business case for that change, and really digging deeper to find out where it came from in the first place and whether or not the issue it was put into place has been addressed. That's what I would suggest.
Yeah, I would just add, healthcare is one of the most dynamic industries you're going to find in our country. And I think we are always sort of trying to follow those needs. So when we did see an influx of private equity investment in our state and out-of-state for-profit owners coming into some of these spaces, there was a response. There was a response that we needed to put up some guardrails and make sure, I was involved for a while, there was a lengthy conversation in our state about regulations over assisted living facilities, right? Like, how do we rewrite hundreds of pages of regs on assisted living to reflect, again, the changing demographics of our state, right? So I feel like there's a really ample opportunity in Maryland to bring people to the table to identify, well, where do we need these regs and why do we need these regs?
Great. Let's do two more questions, and then we want to get you out of here at 11. So we'll do your question, then you guys can pick and choose what you want to respond to.
Thank you very much. Good morning, everyone. My name is Elizabeth Chung from Frederick. Madam Comptroller, thank you so much for bringing this. And you gave me the best birthday gifts today, 75 years old, 75 years old, because it's the first time in 30 years in Maryland that we have healthcare economies together. And I must have to say, first of all, I have a lot of mentors. Some of them are younger than me, like Mark Luckler. I serve as a chair for CHRC 2020. And also, Vinny, I will never forget you bringing me up to serve CHRC and GOSI. So what I want to talk about, Dr. Jacobs, you're the only one that really mentioned CHW. Thank you very much. Hilltop's doing a fantastic job. And Miss Melony, it's good to see you again. So I see all of you folks many years ago. But my question, I have 8, but I'm just at 2 of them. The first one is really cost and the ROI. So what I want to know is that I'm a CHW developer right throughout the states. One of the first 3 accredited training centers. We train 700 CHW. and many of them are newcomers. So thank you, Madam Comptroller, because I'm a newcomer 55 years ago. That's how long I've been in public health, but I couldn't speak English or write English. And yet through the process, people like Vinny, people like the CHRC help me, or HCRC when I serve, right? So many places I serve. So we need to really mentor and equip those newcomers. But my question really have to do with cost. How do you measure the impact of CHW? Ms. Melony, you mentioned that 80% of time that we spend time improving access, improving services by human, the capacity. So really in those matrix with HR1, I want to know how do you measure those? And second is that we also have benefits, HB 871 to believe that, the Medicaid benefits, right? To have to use it on CHW. How do you ensure those, being practiced? So equities again. So I know that I have 8 of them, but I'm just going to give you these 2, cost and data. How do you measure impact of those CHW who dosages of them, right? The talk, the transportation, the counseling, the support. You can never pay the CHW enough. That's my bias. Thank you.
Don't answer yet. Vinny, get your question and then you guys can answer both.
Yeah.
Thank you very much. Thank you, Madam Comptroller and team, for this terrific report. I'm Vinny DeMarco with Maryland Healthcare for All Coalition. We're thrilled that Melony and the Health Secretary mentioned the importance of the Prescription Drug Affordability Board's work to make healthcare more affordable in general. In addition, another great way is to expand healthcare coverage. We commissioned a study by Steve Ports, a prominent economist, showing that when the uninsured rate dropped from 13% to 6%, that decreased uncompensated hospital care by over $460 million, which would have gone into our premiums. Expanding healthcare is one of the best ways to make healthcare more affordable. What are your thoughts on how we go from 6% uninsured to 0% uninsured, which is our goal? Thank you very much.
Floor is yours, guys.
I'll just jump, I'm going to just and it's good to see you, Dr. Chang, and appreciate your work on the Community Health Resource Commission. I know Mark Luckner really appreciates your leadership. Vinny, you have been spending 24 hours a day for the past decade focused on the question that you just addressed this panel to respond to. And so my response is I pick up the phone and call Vinny and say, here's what we've done. We both know what has worked so far. What stone have we left unturned? Because again, in this instance, Maryland leads. We've done an amazing job getting those numbers to the point where the rest of the country is looking at our progress. And so I think we would all be remiss to try to tell you how to do a better job at what you've already done. That is my response.
I can speak to the community health worker question. Thanks for bringing up community health workers. We could have like a side conversation for a long time about this, I think. I would say that the research is pretty clear here. There are randomized controlled trials about community health workers that show that there's an improvement in disparities. All these health outcomes improve, and there's a return on investment, which is crazy, and there shouldn't need to be a return on investment for investment in healthcare workers, but there is for community health workers. And I think it speaks to the importance of having someone that's from the community that understands the trials and tribulations that people in that community face on a day-to-day basis and can connect with them and also translate the sometimes highfalutin language that doctors like I use when we're in the doctor's office. And so I think that the state is making investments in community health workers through the Rural Health Transformation Program. We've also, we recently posted a request for information about social determinants of health and community-based organizations. And a lot of the, I think, a lot of the best employers of community health workers are not necessarily the healthcare institutions that are here, although they can be employers, but the community-based organizations that are also historically employing community health workers. And so trying to figure out ways that community-based organizations can work with health systems, can work with plans to really take advantage of this type of model is just very important, and would be happy to talk more about that with you.
Thanks. The comptroller is going to close this out. I just have to say a quick personal thank you because I engaged with over 60 healthcare stakeholders to put this report together, many of you in this room, and You did not have to give me your time, and you did, and you were very generous and patient with me, and I just really appreciate you. I also don't know if I introduced myself. So to end with that, I'm Danny DeVito, I'm the Population Director, and thank you very much.
Thank you. Thank you, Danny. Yes. Can we give another hand to our panelists for their support here? And a huge thank you to all of you who participated and worked with us on this report. A thank you to Ben Siegel, to Danny, to our communications team. I grew up in DC and in Maryland as the daughter of a pediatric nurse practitioner who worked at a community health center in Adams Morgan. And the daughter of my father was the chair of the board of Children's National Medical Center in DC. So I grew up very much around the healthcare world, and so this report has been extremely interesting for me to understand a different side of it. And I hope that it reflects a lot of your shared knowledge and adds to the policy discussion about how we ensure we are building a healthy state. Thank you all so much. Thank you all so much, and have a wonderful day.